The two common ways to classify anemia are through the kinetic approach and the morphologic approach. The kinetic approach to anemia defines anemias based on how the anemia develops, not the resulting indice changes. So that's going to be a decreased production of RBCs, increased destruction of already circulating RBCs, or a loss through some other mechanism. One of the main categories of kinetic approach to anemia is the increased destruction, which is otherwise known as hemolysis or hemolytic anemia. We have a whole section in Anemia Part 2 that's focused on hemolytic anemias. When that hemolysis does occur, there are some predictable effects, some predictable lab changes, symptoms, complications, so that if you see those within a case, you can go ahead and narrow down the common causes of hemolytic anemias. For simplicity, as we go through these lectures, if there's an anemia that can cause hemolytic anemia, instead of listing over and over what happens to bilirubin, what happens in the urine, things like that, we'll just plainly state evidence of hemolysis, which will summarize these classic and typical effects. So if a later slide just says evidence of hemolysis, this is the evidence summarized here in this table. The CBCs will classically have a normocytic normochromic anemia because we have the ingredients to make a red blood cell. We're just demolishing our supply. In response to a reduction of red blood cell mass, if the bone marrow is healthy, it'll spit out immature red blood cells, reticulocytes or retics, and occasionally that can push the MCV toward an increased range, which is macrocytosis. But still, by and large, normocytic normochromic anemia is the classic presentation. The smear can have schistocytes, which we see here in the right side column, those helmet cells which have arrows pointing to them. Reticulocytes, which can be a direct test, will be increased. Indirect bilirubin, typically increased. If that sounds unfamiliar, make sure you go back to hematology introduction and review erythrocyte recycling. With increased bilirubin, that can manifest as gallstones or jaundice. LDH is increased, it's released from those cells that are lysed. Haptoglobin is decreased, that's going to bind to the hemoglobin that's found floating around when we lyse these cells. The urine can have hemoglobinuria and hemosideриnuria, and that can result in darker urine. For any and all patients who have a hemolytic process going on, we need to suggest folic acid. The folate needs to be replenished. We have very short stores of it, and we use up a lot of it making our RBCs. Iron, if we lyse a red blood cell, think back to RBC recycling. The iron is recycled. We store B12 in our liver for years. So folic acid needs to be our primary focus of supplementation in any type of chronic hemolytic process. The more common classification of anemia is the morphologic approach. This is the micro, normo, and macrocytic anemia classifications. Micro, normo, and macrocytosis are all based on the MCV. The normal range for MCV is 80 to 100. If RBCs are within that range, that's classified as normocytosis. If they're smaller than that, less than 80, that's microcytosis. Larger than that, larger than 100, that is macrocytosis.